Alexander. So I'm going to shift gears and add on the amazing lectures that we had with our esteemed speakers and go to the extreme side of physiology and talk about cardiogenic shock. The focus of the talk will be the latest understanding of the pathophysiology and management of patients with cardiogenic shock. Until now, unfortunately, it's a huge burden in our medical care. We still have lots of patients with cardiogenic shock with high mortality rate, despite all the advancement in the management of cardiogenic shock over the last 50 years. It complicates about 70% of myocardial infarctions, and the incidence has not changed much over the last 15 years. And running a randomized controlled trial in cardiogenic shock still represents a difficult task because of various reasons. And most of the evidence we have in cardiogenic shock management comes from the ischemic cohort of patients. So we have very few evidence on the non-ischemic cohort of patients with cardiogenic shock. And taking you to the definitions, important to start with the definition, and we have two of the important definitions from the ESC guidelines, and you can see the change from the 2016 guidelines, which had hypotension as one of the markers of cardiogenic shock, to the latest definition, which does not include hypotension, because now we know that we can see patients with cardiogenic shock with normal blood pressure and even high blood pressure. So it's very important to think of cardiogenic shock as a low perfusion and low cardiac output, and even sometimes high cardiac output situation, as I will explain to you shortly. And we have the shock trial definition, which has been based on the shock trial registry, which was published many years ago, which also included hemodynamic parameters, cardiac index, and pulmonary capillary wedge pressure. And we have the shock trial, which showed that the early revascularization was the most important treatment strategy in patients developing cardiogenic shock from acute myocardial infarction. And this remains, until today, one of the most significant advancements in managing patients with cardiogenic shock. And you can see that since the 1970s, the significant reduction in mortality happened after the advent of revascularization, which dropped mortality from 80 down to 50%. And even with the advent of mechanical circulatory support, there was no much increase in survival. The mortality remained almost the same according to the latest evidence. But what is cardiogenic shock? It is not just a low cardiac output state, because we can see certain phenotypes, and again talking about precision medicine and phenotyping patients, you can see patient phenotypes with cardiogenic shock even with high cardiac output. So it's important to think of a cardiogenic shock as a multi-organ dysfunction with peripheral hypoperfusion, microcirculatory dysfunction, and pro-inflammatory cytokine release. And the aim is to identify this early and to try to stop the progression before it becomes so late, and before the patient develops the downward spiral of multi-organ dysfunction, which eventually leads to high mortality. And now also we need to think of cardiogenic shock not as a binary situation, because you can encounter different patient phenotypes. It is not just a pump failure, because you can have other complex pathophysiological changes, and also think about the microcirculation, which until today is not tackled effectively. We still mainly look at the macrocirculation and the numbers at the bedside, which mainly reflect the macrohemodynamics. But actually what happens in cardiogenic shock is the relationship between the microcirculation and the macrocirculation. And time is critical. Like anything in acute cardiovascular disease, the earlier the discovery of the situation, the more our ability to stop it. And this is the continuum of cardiogenic shock, starting from a pre-shock state, going into established shock, severe shock, and even refractory shock. And the aim is to identify shock early before the patient progresses into the classic shock stage. And I find ultrasound and echocardiography very important here, because you can identify early signs of low cardiac output by echocardiography even before the patient develops established cardiogenic shock, before the lactate starts rising, which often is a late sign in the development of cardiogenic shock. And the microcirculation microcirculation is important. We already mentioned that it is not well established as a bedside monitoring tool. We don't have a bedside ability to monitor microcirculation. Maybe some clinical parameters can help the assessment of capillary refill time, the presence of mottling in the kneecap, and also the delta PCO2 between the arterial PCO2 and venous PCO2 levels. The more the delta PCO2, the more likely the microcirculation is impaired. But also think about the relationship between the macrocirculation and the microcirculation. And this is an elegant study which showed the effect of microcirculatory dysfunction on the survival of cardiogenic shock patients. You see the blue curve. Patient had a good capillary density, perfused capillary density, good microcirculation, has much better survival than patients with poor and reduced perfused capillary density. And you can see here that even the standard hemodynamic monitoring parameters in both patient cohorts who had normal microcirculation and poor microcirculation, these cohorts had the same mean arterial pressure, the same cardiac index, and the same mixed venous saturation. And the aim is to prevent and detect this early uncoupling between the macro and the microcirculation. And then looking at the spectrum of development of cardiogenic shock, and the early phases of cardiogenic shock is usually a hemodynamic problem. You can support it with inotropes, with pharmacologic therapy, but then the latest spectrum of cardiogenic shock becomes more of a hemometabolic problem, where the patient often has a higher mortality rate, and then you need to think about mechanical circulatory support. And the profiling of cardiogenic shock is the latest way of classifying patients at the bedside. And this is the hemodynamic profiling based on assessment of congestion, depending on which chamber is involved. Is it a univentricular or biventricular congestion? And the role of echocardiography here is very fundamental. And according to the latest registries in heart failure and cardiogenic shock, patients with high CVP and right ventricular congestion had the highest mortality rate among all patients with cardiogenic shock. You can also do the profiling based on both the congestion and the perfusion, utilizing point-of-care echocardiography, and you can see here the different three important categories of cardiogenic shock. You can have a classic patient with cold and wet profile, but you can also see a patient with cardiogenic shock with a warm and wet profile, with low systemic vascular resistance, and this patient will have the worst mortality, much worse than the classic cold and wet phenotype. And you can also have a patient with cardiogenic shock who has been on established long-term diuresis for chronic heart failure, who are cold and dry, because these patients will have lower left-sided filling pressures. And lately we published the first EACBI guidelines on the role of blood ultrasound in acute and chronic heart failure, which integrated the use of blood ultrasound in managing these patients, coupled with the use of echocardiography at the bedside. So, just going quickly through the latest management. Again, the management itself is a huge topic, but I will summarize the latest points. There are now established management algorithms, and this is an algorithm in the latest ESC guidelines to provide a stepwise approach for managing cardiogenic shock. And we're also guided by the latest classification of the American Society of Coronary Angiography and Intervention, which provides a stepwise approach based on the severity of patients and then determining the type of support, whether it is pharmacological or mechanical circulatory support. And ECMO is one of the short-term modalities of support which often represents a bridge to recovery or decision or a longer-term strategy or heart transplantation, which is the gold standard goal for end-stage refractory heart failure. And the latest studies we have in mechanical circulatory support did not provide much hope or promise of benefit until we had the latest trial, which is the Danger Shock trial, just published a couple of months ago, and the New England Journal of Medicine, which utilized Impella as a microaxial flow pump in a big cohort of patients compared to other MCS studies. 360 patients developed STEMI cardiogenic shock and found a significant improvement in the primary endpoints in the group of patients who had the Impella compared to the standard group which did not have mechanical circulatory support. I'm thinking about ECMO and mechanical support as a parachute, so it's vital to know when to open the parachute. If you open it very early, you might cause more complications and bleeding, and if you open it too late, it might be too late and futile and utilization of resources unnecessarily. So that something will come with further studies and experience. And finally, the last point is the importance of the systems of care. Even if we don't have established mechanical circulatory support in our hospitals, it's very important to have shock teams, because the collaboration between cardiologists, the intensivists, the anesthetists, the different members of the multidisciplinary team has proved to be very effective and very important, and also improves the survival. And you can even see that in this study that centers with the highest volume of patients with cardiogenic shock in the presence of shock teams had much better survival and outcomes, and also these patients, interestingly, had the highest number of pulmonary artery catheter utilization. So it's not about the PA catheter has no role. The PA catheter probably has a good role in the right hands, in the centers with good experience. And I will finish with this slide which showed the importance of shock teams, which caused the best reduction in mortality so far, from 50% with revascularization down to 28% in the presence of shock, a multidisciplinary team. So my final take-home message, we still have lots of work to do. The mortality of cardiogenic shock remains high. Revascularization remains